Welcome to the Temple College EMS Professions Trauma presentation. According to the Centers for Disease Control 2018, unintentional injury, i.e. trauma, was listed as a number one reason for death for the infant and children age range. Take a moment, check out this graphic. Motor vehicle crashes. Motor vehicle crashes represent a large portion of those unintentional deaths for the infants and children, whether it be a situation of an unrestrained passenger or an improperly restrained passenger, especially when it comes to some of the infants. Well, what about the auto pedestrians? Unfortunately, the little guys stand little chance of survival when they are hit by a larger moving vehicle, just purely out of the difference in mass and the velocity that's at stake there. Auto versus bicycle. Unfortunately, we do have some situations where the little guys may be out joyriding on their bicycle, pull out in front of a vehicle, and we have an auto ped. We've had a number of situations where these youngsters actually hit the side of a vehicle with such an impact that they would actually total the vehicle. A few other common causes of non-accidental or unintentional trauma may be falls from certain heights, maybe a fall from a tree, a fall from a fence, fall off of a roof. What about diving into shallow water? An unfortunate consequence of living fairly close to Belton and Stillhouse means that we may respond to some of these diving injuries. It's an unfortunate situation when some of the little ones, or even adolescents for that matter, actually jump off some of the cliffs and either impact the bottom of the lake or the bottom of the river. And on occasion, we would actually have an impalement where a tree lurking just below the surface of the water actually impacts a person. And we've had some really nasty injuries from Belton Lake and Stillhouse just from diving into shallow water. Burns. Goes without needing to be said. These can be catastrophic for a number of reasons, but they are very common with children, especially those curious guys and gals that like to play with fire. Sports injuries, head and neck injuries, goes without needing to be said, but we have sports injuries like soccer, where we have neck and head injuries, some spinal injuries, football, obviously. We have baseball types of injuries, wrestling, mixed martial arts, you name it. Sports injuries are something to contend with. You can actually have a number of musculoskeletal type injuries just from the sport itself. And then, of course, we have child abuse. That's an egregious situation that we unfortunately have to deal with in this particular area, more so than some, due to our proximity to Fort Hood and due to certain socioeconomic type challenges that we have in this particular area. Head injuries. It's a common injury site, a common site for an injury. As we've already mentioned, a few of the common causes, whether it be a motor vehicle crash, a fall, a sport injury, a diving injury. Head injuries are fairly common. Obviously, what we'd want to do is just assure that we have an open airway, make sure that we're ventilating appropriately, and watch out for nausea and vomiting. If an individual happens to vomit and they have altered mental status, that can be exceptionally worrisome. And so we'd have to just make sure that we're very aggressive with how we ensure that we have an open airway. Chest injuries with some of these little guys can be quite deceiving. They have soft, pliable ribs, and sometimes we may not necessarily see the outward evidence of the true result of the impact. So carry a high degree of suspicion anytime that the mechanism of injury suggests any type of chest involvement. Again, we may not necessarily see or notice a lot of fractured ribs or issues along the rib cage. Maybe sometimes we might notice a slight asymmetry that's involved, but just remember, carry a high degree of suspicion anytime that a chest could have been involved with the mechanism of injury. Abdominal injuries. A few takeaway points to remember about abdominal injuries. They're more common in children than adults. And just as the situation with the chests, the pliable ribs rather, the abdominal region can hide injuries. They hide injuries very well. And so ever so often you would have this traumatic patient, they start to deteriorate. And if you can reasonably associate an abdominal injury with the mechanism of injury, be suspicious that maybe we have a splenic laceration, maybe a liver injury. There are several structures within the abdominal cavity that, if and when traumatized, could be quite deceptive and really cause some problems for the patient. So always carry a high degree of suspicion with any of these little guys with a possibility of an abdominal injury. One other note, according to the slide, I think is real important to remember is that your efforts to assist ventilations could actually cause problems if done inappropriately. So when you are ventilating these children and infants post-trauma, just be aware that poor ventilation technique may contribute to a distended abdomen. Distended abdomen, for a number of reasons, depending on the injury, could actually worsen the overall situation. So just be aware of that. So you want to be on your A game all the time. Just be aware that with the abdominal injured infant and child, you have to be very, very cautious as to avoid worsening an abdominal injury just because you are ventilating the patient. Okay, a few considerations for trauma care. For the burns, let's cover with a sterile dressing. Let's identify candidates for burn centers. Burn centers are going to be important in the recovery process, especially for significant burns. We have a number of burn centers in the state of Texas, and it is usually accepted that burns greater than 30 to 40% at a third degree level need to be transported to one of the major burn centers as soon as possible. On the aircraft side, that was actually something that we were called out to very often because we would want to fly the patient from the scene all the way to Parkland, UTMB, or SAMC. As far as extremities are concerned, we would want to, in general, manage them in the same manner as we manage for the adults, just on a smaller scale. We'd want to be very aware that some of these types of injuries can be very frightening for some of these children and adolescents. So the mental side of your treatment sometimes is a little bit of a challenge, but otherwise and in general, we would want to manage very similarly as we manage the adult. This slide representing blood volume, it's kind of interesting to note. how the average newborn has approximately 320 milliliters of blood. And I think it's kind of interesting that this particular slide actually draws a reference that a 12-ounce soda can has approximately 360 milliliters of fluid. So roughly a soda can worth of blood. And that's all that we have to play with some of these newborns. So if we have a newborn or infant, we have to be very aware that a little bit of blood loss may actually represent a significant percentage of blood loss for that particular patient. So the traumatized pediatric patient, after they've lost a fair amount of blood, we normally think around 20 to 25% or a fifth to a quarter of their fluid volume. That's when they start to show signs that they are hypovolemic, that they've lost fluid, that they're starting to deteriorate, and so forth. At approximately 30 to 40% of fluid loss, that's when we start to generally see this hypotensive state. Again, keep in mind that the compensatory mechanisms for these little guys is fairly robust. They can hide the fact that they are losing blood internally for a considerable amount of time. Sometimes it's kind of surprising how long they can look actually halfway decent, knowing that they've lost a significant amount of blood. So once those compensatory mechanisms begin to fail, that's when we see a rapid deterioration. And so that hypotensive state, i.e. the decompensated or uncompensated shock, normally occurs or begins to occur right around 30 to 40% of fluid loss. So what exactly are those compensatory mechanisms at play here, especially with these little guys? So ever so often we would have a particular patient that is marching down this pathway. Maybe they've had some sort of significant injury. They may have some internal bleeding that is at play here. One of the first things that we might see, again with maybe a little altered mental status, we may see an increased respiratory rate. We may see an increased heart rate. We may also notice that the child may start to look a little bit more pale, maybe a little bit more cool to touch. All of those signs may be an indication that we are in a compensated state where we've lost some fluid, we've lost some blood, but the patient is still able to maintain perfusion because of these mechanisms. We call those compensatory mechanisms. And just to kind of run down that list again, because they're really important, ever so often you would have an increased respiratory rate, maybe depth and volume, but obviously the rate. We could see an increased heart rate trying to improve or maintain a certain level of cardiac output, and then the massive vasoconstriction, which sometimes presents as a cool to touch and maybe even kind of a pale look. So once again, just kind of looking back over the overall trauma management of these little guys and gals. Obviously, assure the airway is patent and make sure that we're able to ventilate appropriately, oxygenate as necessary. Suctioning may be necessary, especially if we have a lot of maxillofacial type injuries and or secretions and or even altered mental status where maybe they're not able to secure the airway. Also watch out for the nausea and vomiting, specifically for the head injured patient. Just be prepared to suction as needed. Spinal immobilization as needed. That's been a hotly debated topic here recently in EMS. So that is certainly going to be something that you want to speak with your medical director to determine what their level of comfort is. But ultimately, Spinal immobilization has been associated in the past with causing injuries to patients when they are left on the board for extended periods of time. So we are closely watching that debate. Just keep in mind that that's a possibility. You may want to package them appropriately and then obviously transport to the appropriate facility. Okay, so that wraps up the trauma presentation. Please reach out to us if you have any questions or comments, and I hope you have a great day.